السلام عليكم ورحمة الله.
Salam, doctor.
Good morning and a good day for everyone. How many candidates are you? Can you hear me? 36.
Yes.
So still remaining 2 candidates not yet?
Yes, two.
At least 2 or 3.
Two.
Okay, just update me within 10 minutes about them, please. Okay. Let us start by الكتاب. So now Noor Hidayah will present the nephrotic syndrome.
Yes, doctor.
Okay, go ahead, Noor.
Okay. Doctor, since my laptop have my laptop has camera problems, so can I proceed without video?
How come it is in front of, without video, no issue. No issue, but the slides are shared, no issue now.
No, without camera, without my face.
No problem.
Okay. So I will start.
Okay.
Okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Hidayah binti Ikmar, and I will present about nephrotic syndrome. So, okay. So here the content of my presentation about the disease, clinical presentation of nephrotic syndrome, approach to nephrotic syndrome, and congenital nephrotic syndrome. So first one, I will talk about terminology, pathophysiology, and etiology. So terminology, all the terminology are I take from Nelson Pediatrics. So based on Nelson Pediatrics, nephrotic syndrome is defined as a clinical manifestation of glomerular disease associated with heavy proteinuria, hyperlipidemia, hypoalbuminemia, and with edema. And the second one is nephrotic range proteinuria. It must the urine protein must be more than 40 milligram per hour, and the early morning protein creatinine ratio must be more than 2 to 1. And the third one is hypoalbuminemia. The albumin must be lower than 2.5 gram per deciliter, and the last one, hyperlipidemia. The cholesterol is more than 200 milligram per deciliter. So we move on to the pathophysiology of nephrotic syndrome. Basically, the pathophysiology is about an increased permeability of glomerular capillary wall, which leads to massive proteinuria and hypoalbuminemia. So first one, the pathophysiology, there are 2 causes that contribute to the pathogenesis of the nephrotic syndrome. The first one is podocyte. So here, look at the picture. The glomerular capillary is lined by the glomerular endothelium. And this endothelium is covered by the glomerular epithelium, or we can call it podocyte. So podocyte is consists of food process, like this food process here. And in between the food process, there are filtration sleeves. When the protein of podocyte is having gene mutation, or the podocyte is injured, there will be increasing permeability of glomerulus, and resulting the leakage of the protein, and this will cause proteinuria. So the pathophysiology here, I want to highlight about the edema. Based on Nelson, the pathophysiology of edema of the nephrotic syndrome is incompletely understood. But when the increased filtration of plasma protein, this will cause hypoalbuminemia. Then this will lead to the increased plasma oncotic pressure, then resulting in transfusion of fluid from intravascular compartment to interstitial space. So there will be edema. And the second one is immune system. Based on what I read from Medscape, it is a disorder of T cells which release a cytokine that injures the glomerular epithelial fluid processes like IL2, IL4, and IL12. So one of the example for immune system is minimal change nephrotic syndrome that may occur after viral infection and allergen challenge. The MCNS also can occur in children with Hodgkin lymphoma or T-cell lymphoma. So the etiology for the nephrotic syndrome is divided into two, primary and secondary. So the commonest type of nephrotic syndrome in child is primary. Associated with primary glomerular disease without an identifiable causative disease or drug. The glomerular lesion associated with idiopathic nephrotic syndrome include minimal change disease, which is the most common one. And the other two is messenger proliferation and focused segmental glomerulosclerosis. And each etiologies have different age of group, different age group. And the second one is secondary. So nephrotic syndrome may also be secondary to SLE, Hinosh-Schönlein purpura, malignancy like lymphoma and leukemia, and infection like hepatitis, HIV, and malaria. So we move on to the clinical presentation of the nephrotic syndrome. So I will talk about the edema first. Initially, it will give mild edema to the patient. This will give first periorbital edema or eye swelling and lower extremities edema. And this often misdiagnosed as an allergic disorder because the swelling itself will be increased throughout the day. And the edema will become generalized and develop into ascites, pleural effusion, and genital edema. Next one is infection. It is due to loss of protective immunoglobulin in the urine. And the last one, anorexia, irritability, abdominal pain, and diarrhea are common symptoms for nephrotic syndrome. So the clinical presentation of the nephrotic syndrome, I took this picture from pediatric protocol. So the first one is the gross edema of the scrotum and the leg, and also there is abdominal distension from ascites. And this one is the periorbital edema. Next one, I will talk about how to approach nephrotic syndrome, which consists of history taking, physical examination, investigation, management, and prognosis. So history taking. So first, I will read about the clinical scenario. AM, 2 years old Malay boy, was brought to Family Health Care Center (IIM) with 1 week history of facial puffiness. So the chief complaint is facial puffiness. 1 week history. So we must ask the parents about the HOPI first. So we will ask about the site, onset. Is there any other location of the swelling? Because the swelling tend to be at more than one place. Is there any specific time the swelling could be worsened, and the characteristic of the swelling? So the swelling start around 1 week ago. It started with swelling around the eye and gradually progressed to face, lower limb, and abdomen. The swelling worsened in the morning and increased by evening. The swelling is not painful. So, ask any other symptom that will relate associated with nephrotic syndrome. Like, is there any fever? So we can make sure whether the patient has infection or not. Fatigue, loss of appetite, urine output, diarrhea, and irritability. So there is no history of fever, so the patient is not having infection. He appears lethargy and was claimed to be less active. And the urine output is increased. The child also expressed irritability and had diarrhea. So we got the history of the patient. So for the past medical history, so no history of severe disease. He has never been admitted to hospital. No past surgery history. The second one is drug history. He doesn't have drug allergy and he's not taken any drug. So we can conclude that the swelling itself is not due to the drug. The third one, for birth history, the baby was delivered by C-section and weighed 2.745 kilogram after birth. So the birth history seems normal. The development history also normal. The nutritional history, he was fed regularly. However, he lost his appetite around the time the swelling started. So he has lost his appetite, and the family history, no history of similar disease among family members, no history of consanguineous marriage. So we can conclude that the disease itself is not hereditary. And the last one is social history. He was sent to daycare as both parents are working. So there is no abnormality in social history. So for the physical examination, first we must for vital sign we take the temperature, blood pressure, pulse rate, and respiratory rate. For the general examination, we look for fatigue, ill looking, facial puffiness, conscious or irritable, or if the patient have failure or cyanosis. Anthropometry, we can measure weight, height, and head circumference. So for the physical examination, first we look for the skin, look for the rash or features of SLE because as I told before, the nephrotic syndrome may be caused to SLE. Eyes, look for periorbital edema, and limbs, look for pitting edema on upper and lower extremities. Respiratory, look if there is pleural effusion sign, like faint pulmonary auscultation, dullness to percussion, increased tractile familiarity, asymmetrical chest expansion. For the abdomen, we must look for shifting dullness as it is indicated as ascites. And the cardiovascular, look for murmurs or gallop rhythm to rule out heart failure. So upon performing physical examination, the vital sign is normal. And for the physical examination, we noted that the patient feel lethargy and irritable. The patient also has facial swelling, especially at the periorbital area. On lower extremities, there is pitting bilateral pedal swelling. So for the investigation, what we must look first for blood count to check the blood count and to check the albumin count. Next one, renal profile to look for urea, electrolyte, creatinine count. Next one, serum cholesterol to look for hyperlipidemia. Next, liver function test, particularly look for serum albumin level. For urinalysis, we use urinalysis dipstick to look for proteinuria. And then quantitative urinary proteins excretion. We look for protein creatinine ratio or 24-hour urine protein. And to exclude SLE and other causes, we look for anti-nuclear factor, anti-dsDNA, serum complement, C3 level, and ASOT titers to exclude post-streptococcal glomerulonephritis. So the result is the urine dipstick indicate there is proteinuria, but no sign of hematuria. When blood testing show depressed C3 level, so the immunoglobulin level may be low. And then hypoalbuminemia. So and this result will indicate for nephrotic syndrome. Next one, the lipid level also increased, and the urine protein creatinine ratio exceeds 2.0, and the APTT is prolonged. So why we do APTT test? Because we must make sure to see any deficiency of protein factors. This is because when the protein increase, it will lead to alteration in coagulation factors. So here the result. So for management, I take from pediatric protocol and Nelson pediatrics. So basically for treatment, we give corticosteroid therapy. So once a diagnosis nephrotic syndrome has been established, oral prednisolone should be started at initial prednisolone therapy of 60 milligrams per day for 4 to 6 weeks, and then followed by alternate day prednisolone of 40 milligrams per day for 4 weeks. And the maximum dose for this phase is 40 milligrams. And then taper the dose over 4 weeks and stop the treatment. And 80% of the children will achieve remission. Remission is defined as urine trace with negative protein for 3 consecutive days within 28 days. Next one, treatment for relapse. At least children who have nephrotic syndrome at least experience once relapse. So what is relapse? Relapse is defined by urine albumin excretion higher than 40 milligram per hour, or proteinuria higher than 2 plus for 3 consecutive days. So the initial and infrequent relapse introduce the patient with prednisolone at dose of 60 milligrams per day until remission. And then the dose is then changed to alternate day dosing and gradually taper over 4 to 8 weeks. And then stop. Then frequent relapse, it is defined as when the patient has more than 2 relapse within 2 months of initial diagnosis, or having more than 4 relapse within 12-month period. So in this, the prednisolone, same like um, same like the initial and infrequent relapse, and taper dose taper the dose every 2 weeks and keep on as low and alternate day dose as possible for 6 months. So we must taper the dose every 2 weeks for 6 months. 6 months. Then the next one is steroid dependent. Steroid dependent is meaning that the patient will have a relapse while on prednisolone therapy. So so I mean if they we can give the treatment same as frequent relapse, but if the child is having steroid toxic, like if she or he having short stature, cataract, glaucoma, or severe cushingoid features, give them steroid sparing agent. So this is the summary what I presented before. And next one is how to manage the clinical sequelae. So for the dyslipidemia, manage with the low-fat diet and make sure the cholesterol intake is less than 300 milligram per day. So for the edema, children with severe symptomatic edema, including large pleural effusion, ascites, or severe genital edema, should be hospitalized. And no added salt to diet for children who have edema. Diuretic like furosemide are not necessary in steroid responsive patients. And fluid retention is not necessary unless the edema is severe. And the human albumin can be used in symptomatic grossly edema. We combination of furosemide to create diuretic. And the last one is and next is infection. Infection is a major complication of nephrotic syndrome because the patient lost immunoglobulin and has defective cell-mediated immunity because of the loss of protein. So the parents must be counseled if the child have fever or persistent abdominal pain, she or he needs medical intention because it have a high index of suspicion for bacterial peritonitis, and we must give antibiotic. Antibiotic provided must be broad enough coverage to include pneumococcus and gram-negative bacteria. Next one is steroid resistant. It is defined by children who fail to respond to prednisolone therapy within 8 weeks of therapy. So what the doctors must do, refer the child for renal biopsy and kidney function evaluation. So how to manage this situation? We can manage the symptom like control of edema by restriction of sodium, by giving diuretic like furosemide, and to control hypertension by giving SVE inhibitor like captopril, and evaluate calcium and phosphate metabolism. Immunization. Pneumococcal vaccine should be administered to all children with nephrotic syndrome. This is because it is as a prevention of invasive pneumococcal disease in children in nephrotic syndrome. Ideally administered when the child is in remission and off daily prednisolone therapy. Live virus vaccine should not be administered to children who are receiving daily or alternate day high dose steroid. Next one is alternative to steroid. meaning we give medication other than steroid. So, so for who we must give this treatment, to steroid-dependent patient, frequent relapsers, steroid-resistant patient, child who has severe corticosteroid toxicity. So, first one is first medication is cyclosporine. It prolongs the duration of permission and reduce the number of relapse in children with frequently relapsing and steroid-dependent nephrotic syndrome with sign of steroid toxicity. So, before begin this treatment, the parent and the doctor must review beforehand because the side effect might be affect the future of the child, and like leukopenia, alopecia, hemorrhagic cystitis, gonadal toxicity, and may lead to malignancy. And the dose is 2 to 3 milligram per kilogram per day for 8 to 12 weeks. We must monitor for blood count and urinalysis twice weekly, especially white blood cell count. And the drug must be withheld if the white blood cell drop. And the the alternate day prednisone therapy is often continued during the course of cyclosporine administration. And then the next one is calcineurin inhibitors, which are cyclosporine and tacrolimus. It is effective in inducing and maintaining prolonged remission in children with steroid-resistant nephrotic syndrome. It also useful as steroid sparing agent. And the side effect also should be monitored, like hypertension, nephrotoxicity, hirsutism, and gingival hypoplasia. And the next one is mycophenolate. It is to maintain remission in children with steroid-dependent or frequently relapsing nephrotic syndrome. And the last one is levamisole. It is an anthelmintic agent with immunomodulating effects that has been shown to reduce the risk of relapse in comparison to prednisolone. So most children who respond to cyclosporine, tacrolimus, or mycophenolate tend to relapse when the medication is discontinued. So prognosis. So most children with steroid responsive nephrotic syndrome have repeated relapse, which generally decrease when the child grows older. And this is unlikely to develop chronic kidney disease. The disease and the child will remain fertile unless the child has prolonged cyclophosphamide therapy. And the family should be informed about this prognosis. And to minimize the psychological effect on children during the treatment, children with nephrotic syndrome should not be considered chronically ill and should participate in all age-appropriate childhood activities like playing with friends and go to school like usual, and maintain an unrestricted diet when in remission. But children with steroid-resistant nephrotic syndrome, most often caused by FSGS, generally have a much poorer prognosis. These children will develop progressive renal insufficiency. This will ultimately leading to end-stage renal disease requiring dialysis or kidney transplantation. So the last one is the congenital nephrotic syndrome. So it is defined as nephrotic syndrome manifesting at birth or within the first 3 months of life. It has a poorer prognosis when it occurs in the first year of life when compared to nephrotic syndrome manifesting in childhood. And the primary, it is divided into primary and secondary. The primary congenital nephrotic syndrome is due to a variety of syndrome, inherited as autosomal recessive disorder, like there is mutation on gene. And the it is secondary to a number of etiologies such as in utero infection, for example, toxoplasmosis, syphilis, or HIV. So based on Nelson, in UK, more than 85% children with congenital nephrotic syndrome present with mutation of 4 gene. And the first 3 encode component of the glomerular filtration barrier. So there are 3 types of the primary congenital nephrotic syndrome. The first one is the Finnish type. Finnish type congenital nephrotic syndrome that caused by mutation in NPHS1 or NPHS2 gene. They encode nephrin and podosin. And this will affected infant most commonly present at birth with edema due to massive proteinuria. And also the infant will have severe hypoalbuminemia, hyperlipidemia, and hypogammaglobulinemia. And the next one is Danish Drive syndrome. It is caused by a mutation in WT1 gene, which results in abnormal podocyte function. Patient will present with early onset nephrotic syndrome, progressive renal insufficiency, ambiguous genitalia, and glioblastoma. And the next one is Pearson syndrome. It is a mutation in the LAMB2 gene, and this will lead to abnormalities of beta-2-laminin, a critical component of glomerular and ocular basement membrane. So this is etiology that I got from congenital nephrotic syndrome and the secondary infection drug. And next, the clinical features is actually same with the nephrotic syndrome in childhood, which are edema, hypoalbuminemia, oliguria, and massive proteinuria. For screening, we see the elevated AFP levels from maternal serum and amniotic fluid. And for diagnosis, we do the genetic analysis. Genetic analysis has led to more specific diagnosis rather than do kidney biopsy. And this test must be performed before proceed to the treatment because patient might not responsive to the immunosuppressive therapy. And the next one is management. For the secondary congenital nephrotic syndrome can resolve within treatment of the underlying cause. And the primary congenital nephrotic syndrome, we treat the symptom like how to manage the edema by giving intravenous albumin and diuretics, medication SE inhibitor, and aggressive nutritional support. This is because the infant may lose protein through urine. Then this will cause the baby have protein malnutrition, and this will lead to development problem. And the complication is failure to thrive, recurrent infection, and hypothyroidism. So this is my reference. Okay, thank you. Is there this question?
Can you come back to your references? You put the references by a good scientific manner, but you can find here that this is Nelson, which is 20th edition. Now we have the 21 edition, which came at 2021. And as you know, many things can change with this 5 years. Okay, what is got updating from the latest pediatric protocol? Good. So this is the most important. Please, in any presentation, we must go for the latest edition for book. And our UIA library is giving us off campus now. You can go from home and open the library and get like up to date, getting the last update for your one. Okay. The protein albumin ratio now, I think it is different measures, 0.2. Okay, you need to revise it, please. And then you need to revise the protocol for treatment again for corticosteroid. And we need to add the side effect of corticosteroid because we are, as you said, we are using this corticosteroid for a longer time and sometimes for prolonged time if there is steroid dependent. So we must know the side effect of steroid, which is Cushing syndrome. We need to add it even as a one picture. Okay.
Okay.
So Hidayah, speak to you now. That we,
Yes.
Your name is Hidayah, yes?
Yes.
So today we can know that if you are speaking about nephrotic syndrome, it is better for your professional now. If you see a case of nephrotic syndrome, you must be able to say, is it primary or secondary?
Okay. Yes. Okay.
Number two, is it steroid dependent or steroid sensitive?
Okay.
Is it, what about the relapse, multiple relapse or not? And what is the complication? So if you are presenting, try to put yourself in a good frame. So you know, this is primary or secondary nephrotic syndrome, which look minimally change disease, which is steroid sensitive. Okay, you must add, very important, the indication also of renal biopsy.
Okay.
We are not going to do it, so you need to add this point, please, to your one and revise steroid protocol again, make correction, and then you can resend it again, please.
Okay.
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 Your colleague, any questions or not? Okay, so we can go for the second session.
Wait, sorry, I have some technical issue. Okay, can you see my full slides?
Yes.
Yes.
This. Okay. 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 Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Sharifah Haja binti Said Jamaluddin, 1813106. Today I will present about acute glomerular nephritis. Okay. This is the contents of my presentation. Introduction, epidemiology, etiology, pathophysiology, and also we will try to approach a case of children to acute glomerular nephritis with regards to the history taking, physical examination, investigation, and also management. And lastly, we go to the prognosis. Okay, so for introduction, this is the anatomy of the kidney. Okay, we know the kidney have very important function such as hemostasis function to excrete waste from our body, and also to maintain water, electrolyte, and also acid-base balance. And also it has hemostatic function, endocrine function, regulation of blood pressure, and also regulation of blood calcium level. Okay, so we have the glomerulus inside the kidney. So glomerulus it function to filtrate substance. As you can see here, it has some cells. The important one include the messenger cell in the center, and also we have epithelial cell here, and parietal epithelial cell here, and this is the Bowman capsule. So from this anatomy, there are some glomerular injury that affect on the glomerulus, and it will cause some disease, renal disease. Okay, so for the definition of acute glomerular nephritis, it is a specific set of renal disease which immunological mechanism triggers inflammation and proliferation of glomerular tissue. It can also define as abrupt onset of one or more features of an acute nephritic syndrome, which edema, example like facial puffiness, micro or microscopic hematuria, microscopic like we can see with our naked eye, tea-colored or smoky urine, oliguria, low urine output, hypertension, and also azotemia. Azotemia is the kidney have been damaged or injured, so we can check it by blood urea nitrogen and creatinine levels, which will increase. Okay, we go to the epidemiology. So for acute glomerular nephritis, it accounts for about 90% of renal diseases in childhood, and it represents 10 to 15% of glomerular disease. And for worldwide, the most common one is IgA nephropathy, and in Malaysia is post-streptococcus glomerular nephritis. Okay, so this is the acute post-streptococcus glomerular nephritis. It is most common in age 5 to 12 years, but it is uncommon below than 10 years. And it develops 1 to 2 weeks after pharyngitis, or 3 to 6 weeks after pyoderma. And it is predominant in male compared to female with 2 to 1 ratio. Okay, so what is the etiology of the AGN? So we can classify it based on the primary and also secondary glomerular nephritis. So for primary, it is the disease is isolated to the kidney itself. The example like membranous glomerular nephritis, IgA nephropathy, Buerger disease. For secondary, the renal disease is a component of systemic disorder. It means it's not primarily from the glomerulus, it's from the other side. So it affect the glomerulus, such as post-streptococcal glomerular nephritis, other post-infectious GN, infective endocarditis, and also SLE and others. Okay, we can also classify it based on infectious or non-infectious. So infectious, the most common one is bacterial, which is Streptococcus. It can also be caused by the fungi, parasites, and others. So for non-infectious, it will also be caused by the multi-system disease like SLE and others. It can also caused by the primary renal disease like membranoproliferative glomerulonephritis, rapidly progressive glomerulonephritis, and also others. Okay, so this is the cellular location of injury. So that's why the anatomy is very important, because there are specific cells that are involved with the in the glomerulonephritis. So this is the messenger cell, epithelial cell injury, and also endothelial cell injury. So these are the diseases that affect those cells. Okay, and then we go to the pathophysiology. So this is what I found from the Robbins basic pathology. There is two main mechanisms. I will go this first. Antibody reacting in situ within glomerulus, either is intrinsic or extrinsic. It means the antibody is act on the glomerulus itself. So the second mechanism is deposition of antigen-antibody complex in glomerulus. It means the antigen-antibody complex may come from any other sites, but it deposits at the glomerulus. So this is the pathophysiology. I know it's quite complicated, but I will try to go one by one. Okay, so for the blue one, you can see it is the pathophysiology. Purple about the mechanism. Green one is sign and symptom, and the pink is complication. So what I've said before, the mechanism, you can see here. Okay, this is the first one. The immune complex formed in situ in glomerulus. It means it is from at the site of the glomerulus. The disease is this, and also it can be caused by immune complex deposit into glomerulus from circulation. It means the immune complex is from other side, and then it deposit at the glomerulus. This is also include the post Streptococcus glomerulonephritis and IgA. Okay, so from these two main mechanisms, it will cause inflammation and proliferation of cell in glomerulus, and then inflammatory process damage the capillary walls. So when the capillary walls is damaged, so we can so the glomerulus is permeable to red blood cell. So that's why you can see visible hematuria and also red blood cell cast in microscopy and others. So the other one is also it's permeable to protein. We can see also some mild proteinuria because it is permeable to protein. And from the proteinuria, it can also cause low GFR, azotemia, oliguria, and also it activates the RAS system, which increase the sodium and water retention and cause hypertension. Okay. Okay, we proceed to the approach to acute glomerulonephritis. This is the case scenario. A 6-year-old girl presented to suspect with complaint of hematuria for 7 days duration. Okay, so the main complaint is hematuria. So for AGN, the presenting features can be acute nephritic syndrome. That I said in the definition. It is the most common presenting features, and it can also come with nephrotic syndrome, rapidly progressive GN, hypertensive encephalopathy, pulmonary edema is the complication of it. And also it can be subclinical, detected on routine exam. Maybe because of the urine examination, maybe we can see the You can see the hematuria and also subclinical. Okay, so first start with the history taking. So the doctor need to ask regarding the complaint, the specific color of the urine, is it cold, tea, smoky, and also characteristic. Frothy may suggest protein in the urine, volume, painful or not. So the patient said it is cola colored urine, quite frothy, and small volume of urine, and does not feel pain during urination. Okay, so the doctor then asked about the other symptoms like fever, edema, hypertension. Fever may suggest the infection, edema, sodium water retention, hypertension can because of the RAS system also, headache, shortness of breath, rash may because of the SLE or skin infection, and also visual disturbance. And the patient had fever and she recovered from sore throat about 1 to 2 weeks ago, and she did not notice any edema. So we know that this patient had maybe had infection. So we can proceed. Okay, so what is the signs and symptom of the glomerulonephritis? It also include headache, high BP, lethargy, low-grade fever. So this is the more specific. Okay, so for the specific symptom, edema, it can be periorbital, scrotal, or pedal. Facial puffiness, early sign. Smoky or tea-colored urine, reduced urine output. And for non-specific, the patient may have anorexia and lethargy, and also abdominal pain. So for complication, patient may have shortness of breath because of the pulmonary edema, dizziness, headache because of the hypertensive encephalopathy. For the signs, we can look for the cardinal feature of AGN, which are edema, hematuria, with or without proteinuria, uremia, oliguria, and also hypertension. For general sign, can look at the hypertension, papilledema, and also any skin lesions. Okay, so for complication, it also include the central nervous system, which are the hypertensive encephalopathy. For early sign, restless, drowsy, and also headache. For late sign, it can come with visual disturbance, vomiting, and also seizures. For respiratory system, it can also cause pulmonary edema. And then renal nephrotic syndrome, irreversible renal failure. And for blood, it can cause severe uremia, hyperkalemia, and also it can cause cardiac arrest. This is because mainly because of the kidney cannot function very well because it cannot filter because the RAS system is activated, and then it can cause hypertension and sodium water retention. Okay, so then we need to ask other history that related, past medical history like the infection, sore throat, or any skin infection, underlying systemic disease like purpura, abdominal pain, and also we can also ask regarding butterfly malarash and also atralgia, which suggests SLE. And we need to ask regarding the birth history, antenatal and perinatal history, immunization history, complete immunization based on the Ministry of Health recommendation, nutritional history, as the patient has loss of appetite, drug history, recent medication exposure, like antibiotic, family history, is there any family in any member in your family have autoimmune disorder or renal failure, like have dialysis or kidney transplantation. Okay, so this is the main cause of the glomerulonephritis. which is acute post-streptococcal glomerulonephritis. So it accounts about 80 to 90% cause. So it commonly caused by the group A beta hemolytic streptococcus. So this picture here, it is very important. So you can see here, after 2 weeks of streptococcal infection, we can see many signs. Okay, so like this, after 2 weeks, we can see the weight, urea, and hypertension will decreasing, and also the anti-streptococcal antibody titer is decreasing until 6 weeks, and also complement. This is the normal one. So for complement, it is low at first, and then it will increase gradually until at 6 weeks. Okay, so for hematuria, it can persist up to 1 year. So for pathophysiology, just like what I said in the before, so we need to, it is really important for us to remember that it is not because of the infection that attack the glomerulus, but it is because of the immune complex that form. So it is deposit at the glomerulus. Okay, so we proceed to the physical exam. So first one, we need to look at the general appearance like consciousness and alertness, lethargy, respiratory distress, and also edema. It can also suggest the severity and also the complication of the disease. Anthropometric height and weight, and also vital signs, temperature, blood pressure, respiratory rate, heart rate, and also SpO2. Okay, so then we need to check also for the other physical exam, like nose and throat, look for ulcer or throat infection, edema, periorbital, lower limb edema, skin for red patches. It can also suggest the SLE. Lung, pleural effusion can be caused from the complication, and also heart murmur, abdomen to look for hepatomegaly and also splenomegaly, and also head and neck, cervical lymphadenopathy. Okay, this is the happiness. This is very orbital edema. So this patient, it looks conscious and stable. She looks lethargic, mild facial puffiness, and also mild hypertension. Her weight is slightly increased because of the edema. So no hypertrophic splenomegaly or any skin rashes. And then we proceed to the investigation. So for the urinalysis and culture, there is hematuria. And then proteinuria. Proteinuria, it usually does not have a massive proteinuria like in nephrotic syndrome, but it can also trace up to 2+ or even more than 2+, then we can consider nephrotic syndrome. And there is also red blood cell cast in the culture. So this is very suggestive of the nephrotic syndrome. And also pyuria may also present bacteriological and serological evidence, because we need to know, because the most common cause of the acute glomerulonephritis is streptococcal infection, right? So we need to find a clue or evidence of strep infection like ASOT, anti-streptococcal antibody titer more than 200, and then increase anti-DNase B if it is test is available. DNase B is antibody that made by group A beta hemolytic streptococcus, which if it is rise, it can also indicate rheumatic fever, post-streptococcal glomerulonephritis, strep throat, and also skin infection. Okay, and then throat swab and also skin swab to look for the bacteria. And then for blood, FBC, the white blood cell will increase because of the infection. And it is important also to look for renal profile because it is related to the kidney, right? So the blood urea, serum creatinine, we need to check because check the renal function, and also the GFR may reduce, and electrolyte to look for electrolyte imbalance, and complement levels. So C3, it is low at first and it will normalize by 6 weeks. Okay, and also immunological marker for SLE, and also ANCA for vaginal spermatosis and polyarthritis. For imaging, you can also do chest X-ray for vaginal granulomatosis, and also but for biopsy, it is only indicate if some of these features like steroid resistant, atypical presentation, but it is not commonly done because it is the invasive procedure. And if it has these features, it may delay the resolution, like oliguria more than 2 weeks, azotemia more than 3 weeks, cross hematuria more than 3 weeks, and also persistent hematuria more than 6 months. Okay, so for lab finding, this is how the cola colored urine look like, and this is the red cell cast. The red cell aggregate or stick to each other. Okay, for this patient, it shows the high white blood cell, high leukocyte, proteinuria, hematuria, and then the culture of throat swab, presence of streptococcus. So it may suggest the acute post-streptococcal glomerulonephritis. Okay, and the C3 also reduced. Okay, for differential diagnosis. Okay. Okay, so this the patient may come with clinical feature of acute glomerulonephritis. So we can look at the serum complement. If it is reduced, it can be caused by lupus nephritis, shunt nephritis, and also for renal disease. It is can caused by the acute post-infectious glomerulonephritis, and also some others. For the normal serum, it goes here. So for if it is low serum complement, we need to check it for the ASO, anti-DNase B, streptozyme test for look for the any streptococcal origin infection. Okay, so if the C3 is normal by some week, so it will suggest the acute post-streptococcal glomerulonephritis. Okay, if it is negative, it can be all of these, lupus nephritis and also others. Okay, so this is some other renal diseases. I will not read all this. You can look at it after this. This is to differentiate some of the renal disease. But we look, this is the most common one, acute post-streptococcal glomerulonephritis. Okay, so for diagnosis, like what we have said before, we need to look for the detailed history like the streptococcus infection and also ASOT, raised and low C3 level, and return to normal after 3 to 4 weeks. For post-streptococcal glomerulonephritis, we need to look at the ASOT, and for good pasture syndrome, we need to look at the ANCA, anti-neutrophilic cytoplasmic autoantibody. So this is differences between the nephrotic and the nephritic. The nephrotic can come with the massive proteinuria, and nephritic syndrome is more for the hematuria, massive hematuria. And the urine cast, it is red blood cell cast. Okay, so for management, It is mainly supportive management. Supportive management like to repair the kidney function. Like the first one is strict monitoring, strict like the fluid intake, urine output, daily weight, and BP. And this one, for the infection, we need to give penicillin for 10 days or erythromycin for the patient who cannot tolerate penicillin to eliminate the infection. Fluid restriction to control edema, diuretic for pulmonary edema and also the hypertension. Diet, salt-free, because there are so many, because the patient have many salt in the body because of the retention. And the complication, so for hypertensive, encephalopathy, pulmonary edema, and also the acute renal failure. And dialysis is just for acute pulmonary edema, hyperkalemia, severe acidosis, and also uremic symptoms. Okay, so for management, which is more specific for infection, antibiotic, edema, diuretic, hypertension, severe acute kidney injury, need to go to dialysis, hyperkalemia, give the calcium gluconate and also others. And also for pulmonary edema, we need to give oxygen and also other medical and also other medicine. Okay, so for prognosis, usually the proteinuria and edema will decline rapidly for 5 to 10 days, and the hypertension and gross hematuria normally resolve by 2 to 3 weeks, and C3 will return to normal. Microscopic hematuria can go to months to year, and generally it has excellent prognosis because it is a self-limiting disease with more than 95% recover completely, and minority of patients progress to renal failure disease. So it is also important for the patient to have follow-up after the proteinuria and hematuria has fully resolved. So at least 1 year at 1 to 3 months interval, and you need to do urine FME and renal function tests to evaluate the recovery. Need to check for the electrolyte and others. And also it is important to monitor BP at every visit. Okay, I think that's all from me. Thank you.
You better to write any references by scientific way, please.
Okay.
You can prepare between you. Simple one, just present it to you how to write the protocol as the references. Okay. The most important, you must both of you must specify about the input-output chart. Okay, for both nephritic and nephritis, and the weigh scale. You must weigh the patient like daily to know how it, because most of the edema came because of rapid gaining of weight. I would like to ask you why it is nice presentation first. Thank you. Why it is cola like, not blood?
What?
You said it is hematuria, yes?
Yes.
So why it is cola, not blood, not fresh blood?
Because I think I've read it before.
Anyone can answer? No issue.
I think
Anyone can answer why it is cola or tea?
I think for the what I've read, the hematuria fresh blood because of the urinary tract infection. But I'm not sure also.
This blood is coming from the glomeruli up.
Oh.
Remember, it looks like the same if anyone have GIT bleeding. From up, it will come down as amylina. If it is down, it will come as a fresh blood. Here, it is the same. If you found fresh blood, usually it is not glomerulonephritis. It is pure hematuria, which can be severe UTI, which can be malignancy, which can be whatever, and the blood will come as a blood. But for glomerulonephritis, the blood will be destroyed, and we get hemoglobinuria at that time. That's why the color is color. So if you see fresh blood, usually it is not glomerulonephritis. You must search for the cause. And usually it is lower one from cystitis like that. So, okay, good presentation. Anyone has a question?
Doctor?
Yes.
Actually, I have a question. Can I ask a question regarding the renal biopsy?
Yes.
Is it because because we cannot know what the cell injury when we don't do the biopsy, right? So is it we need to do the renal biopsy? Is it commonly done?
You mean for nephritis or for nephrotic or for what?
Nephritis.
Yeah, because if case is straightforward and responsive to treatment, I think it is not done as a routine. But sometimes there is a mixed picture of nephritic, or it is nephrotic syndrome, and it looks like not straightforward as minimal change, and or steroid non-resistant, non-sensitive. So you must go through just to go to up to date and write what is the indication for renal biopsy, and both if you need to add it. And you need to add really the most important issue is the input-output chart, way scaling, and continuous monitoring. I need, because both of nephritic and nephrotic are in danger. The nephrotic syndrome, in spite he is edematous, sometimes he can go choke because of severe hypoalbuminemia, making the fluid restricted to the interstitial, but the intravascular component are very, very less. And the otherwise, for glomerulonephritis also, the child has edema, but it can affect even the brain, and came with many cases came to us just by convulsion. And when we measure the blood pressure, we found it high. When we asked it, we got the result. So it is very important to take care about the input-output chart. Of course, we may need to do a restriction in case of glomerulonephritis, and we must do also judicious use of diuretics. We are not giving it as a routine unless needed, so we must give it as a routine with albumin transfusion, like in case of nephrotic syndrome. So that is the issue of medicine. It must be a wise decision. Okay.
Okay, thank you, Doctor.
Let's go for the third presentation.
Assalamualaikum. Can you guys hear me?
Waalaikumsalam. Yes.
First of all, my connection is quite unstable. So if you guys cannot hear me, let me know. Bismillahirrahmanirrahim. My name is Nur Afika binti Muhammad Asri with metric number 1815494. and I will be presenting about the urinary tract infection in childhood. Next. So this is the content of my presentation, which include introduction and etiology of UTI, its predisposing factors, pathogenesis, signs and symptoms, complication, prevention, and how to approach pediatric patient with UTI. So next. So urinary tract infection is defined as growth of bacteria in the urinary tract or combination of clinical features and presence of bacteria in the urine. So next. So this is the prevalence of UTI in childhood. So UTI comprises 7% of febrile illnesses in early childhood. And the prevalence of UTI varies with age. So in girls, the first UTI usually occur by the age of 5 years, with peaks during infancy and toilet training. While in boys, most UTIs occur during the first year of life, and it's common in uncircumcised boys. And before the age of 2 years, 2.1% of girls and 2.2% of boys will have had a UTI. Next. So UTI can be categorized anatomically into upper tract and lower tract infection. So upper tract UTI involve infection and inflammation in the kidneys, which is known as pyelonephritis, and ureters, which is known as ureteritis. While lower tract UTI involve infection within the bladder, which is known as cystitis, and urethra, which is known as urethritis. And there is also a condition in which there is a positive urine culture without any manifestation of infection, that known as asymptomatic bacteriuria. And this condition is common in girls. Next. So next is the etiology of UTI. So the most common causative organism are from the intestinal flora, which is caused by E. coli. E. coli accounts for 80 to 90% of UTI in children. And other gram-negative bacteria include Klebsiella pneumonia, Proteus mirabilis, that is common in boys than in girls, Enterobacter aerogens, and Citrobacter. For gram-positive bacteria, Staphylococcus saprophyticus is very common in sexually active female adolescents, and it accounts for more than 50% of UTI. And other gram-positive bacteria include the Enterococcus species and Staphylococcus aureus. Next is virus. So viruses such as adenovirus, enterovirus, Coxsackie virus, and ecovirus may also cause UTI. And the associated infection is usually limited to the lower urinary tract. And in this regard, adenovirus are known to cause hemorrhagic cystitis. While for fungi, such as Candida species, Aspergillus species, Cryptococcus neoformans are uncommon cause of UTI, and it occurs mainly in children with an indwelling urinary catheter, anomalies of the urinary tract, long-term use of broad-spectrum antibiotic, or in children with a compromised immune system. So next. So next is predisposing factors of UTI. So first one is urinary obstruction. So children with obstructive urology abnormalities are at increased risk of developing UTI. Why? It is because stagnant urine is an excellent culture medium for most uropathogens. And the predisposing obstructive abnormalities include the anatomic condition such as posterior urethral valve or uretero-pelvic junction obstruction. Other than that, neurologic conditions such as myelomeningocele with neurogenic bladder also can increase risk of getting UTI. Next is functional condition such as bladder and bowel dysfunction. So second predisposing factor is the host condition that may facilitate entry of the organism. So such condition include the lack of circumcision. So from what I have read, it is stated that uncircumcised male infants with fever have a 4 to 8-fold higher risk of UTI than circumcised male infants. And the plausible mechanism that have been proposed to explain this difference is because of the mucosal surface of the uncircumcised foreskin is more likely to bind uropathogenic bacterial species than the keratinized skin on a circumcised penis. And other conditions that can facilitate entry of the organism include surgery or instrumentation and catheterization. And it is stated that the risk of UTI will increase with increasing duration of bladder catheterization. Next predisposing factor is incomplete bladder emptying. And the contributing factor include the infrequent voiding, obstruction by loaded rectum from constipation. This is because the child trying to retain urine to stay dry, yet the bladder may have uninhibited contraction, forcing the urine out. So the result may be the incomplete bladder emptying. So next is female infants. Female infants have a 2 to 4-fold higher risk of UTI than male infants. And this has been presumed to be the result of anatomy difference, as female has shorter urethra than male. Behavioral activities such as sexual activity, toilet training, and tight clothing may also predispose to UTI. Next is genetic factors. So it is stated that first-degree relative of children with UTI are more likely to have UTI than individual without such history. Next. So next is vesicoureteral reflux, or VUR. So VUR is retrograde passage of urine from the bladder into the upper urinary tract, and it is the most common urologic anomaly in children. And children with VUR are at increased risk for recurrent UTI. And there are 4 grades of VUR that depends on how far the urine backs up. So next is the pathogenesis. So usually urinary tract infection is a result of ascending infection. So colonization of the periurethral area by uropathogenic enteric pathogen is the first step in development of a UTI. So the pathogen will attach to the uroepithelial cells via an active process that mediated by glycose injolipid receptor on the surface epithelial cells. And this bacterial attachment will recruit toll-like receptor. And this toll-like receptor binding will trigger a cytokine response. And because of the bacteria have variety of virulence factor, it enables them to ascend into the bladder and kidney. And it will result in bacterial inoculum in the kidney, and it will generate an intense inflammatory response. So next is signs and symptoms. So in infant, usually clinical signs are often absent, and differentiating between the upper and lower UTI is less obvious. So signs and symptoms in infant include fever, vomiting, lethargy or irritability, poor feeding, jaundice, septicemia, and offensive urine. While in children, they may present with signs and symptoms suggesting the site of infection, such as dysuria and frequency, abdominal pain or loin tenderness, fevers, lethargy and anorexia, vomiting, diarrhea, hematuria, offensive or cloudy urine, and recurrence of anuresis. So next is complication. So complication is divided into acute and long-term complication. And dehydration is the most common acute complication of UTI in pediatric population. And the long-term complication of UTI are hypertension, impaired renal function, and end-stage renal disease. And children with UTI may also develop renal abscess. And from what I have read, approximately 10 to 30% of children with UTI will develop some renal scarring. So next is prevention. So prevention, the aim of prevention is to ensure wash out of organism that ascend into the bladder and reduce the presence of aggressive organism. So the first one is to teach the older children proper hygiene for maintaining a clean genital area, such as do not overwash the area, avoid hot bath, and do not use soap for washing while symptoms are present. Next is to teach the child safe wiping techniques, which is wiping from the front to the back, as doing so avoids the risk of UTI caused by bringing in bacteria from the rear, as E. coli is the most common causes of UTI, right? So next is in younger children, parents should change the diapers frequently. So drinking water helps to dilute urine. They should urinate more frequently, allowing the bacteria to flush from the urinary tract before an infection can begin. Next is encourage the children to use bathroom frequently rather than holding in urine. And next is avoid bubble bath that can irritate the genitals and urethra. And last one is prophylactic antibiotics, and this will be discussed later. So next, so let's move on how to approach pediatric patient with UTI. So this is the example of case scenario. Jack, a 2-month-old infant, stopped feeding and had a high intermittent fever for 3 days, and he was referred to hospital where he had an infection screen. So next. So from what I have read, UTI should be suspected in children that less than 2 years old presenting with fevers. So children with UTI symptoms should be evaluated promptly, as prompt recognition and treatment of UTI may be important in the prevention of renal scarring. So the first one, the history of presenting illness should include the duration of fever, urinary symptoms, any abdominal pain, or suprapubic discomfort. For the past medical history, it should include the risk factor for UTI, including the chronic urinary symptoms, chronic constipation, previous UTI or previous undiagnosed febrile illnesses, or vesico-urethral reflux. For drug history, it is also important, as from what I have read, it is stated that nephrotoxic drug can lead to renal insufficiency, and it can predispose the child to UTI. So next is birth history. It should include either the patient has been antenatally diagnosed with renal or urinary tract abnormality, such as horseshoe kidney, duplicated ureters, or polycystic kidney disease, as it can also predispose the child to UTI. Next. Developmental history also important. So for nutritional history, it can give us idea about the patient's adequacy of nutrients. So we can know, is there any malnutrition that caused by loss of appetite, because children with UTI may be irritable and refuse to be fed. So for family history of frequent UTI, BUR, and other genitourinary abnormalities also important, as we have discussed that genetic is one of the predisposing factors for UTI. So next, social history also important, because any sexual abuse also can predispose the child to UTI. Next. So for physical examination, the first one is general examination. So in general examination, we should check either the child is conscious or alert, or child is respiratory distress, irritability, or any signs of dysmorphism, pallor, jaundice, lethargy, or any sign of malnutrition. For vital sign, we should check for heart rate, respiratory rate, temperature, and from what I have read, temperature greater than or equal to 39 degrees Celsius, it is associated with acute pyelonephritis that may cause renal scarring. Also, we can check for blood pressure, oxygen saturation, and pulse. For the anthropometry, we should check for height, weight, and head. We should measure the height, weight, and head circumference. And poor weight gain may be indication of chronic renal failure due to renal scarring. And in abdominal examination, if there is suprapubic and costovertebral angle tenderness, it is an indication of UTI. And if there is enlarged bladder or kidney, it also can indicate urinary obstruction, and palpable stool in the colon also may indicate constipation, and all of these may predispose to UTI. Next. So examination of external genitalia for any anatomic abnormalities such as phimosis, hypospadias, or labial adhesion, and check for any signs of vulvovaginitis, vaginal thrombody. Also important as it also may predispose to UTI. Next is evaluation of lower back for any signs of occult myelomeningocele such as midline pigmentation, lipoma, vascular lesion, sinus, or tuft of hair that may be associated with a neurogenic bladder and recurrent UTI. So next is investigation. So in investigation, collection of urine is important, and the recommended method is clean cache specimen. So for the diagnosis, so for the result in the urine full examination and microscopic examination, it should be pyuria, which is more than 10 pascal and greater than or equal to 10 to the power of 5 colony-forming unit per milliliter of single organism is diagnosis for the culture and sensitivity. So for blood examination in full blood count, so patient with UTI should the result should be leukocytosis, neutrophilia, increased erythrocyte sedimentation rate, increased CRP. Also, there will be increase in white cell count, serum procalcitonin, and blood culture should be done before initiating any antibiotics. Next is imaging. So the first one is ultrasound scanning. It can show any dilatation of the upper tract, the renal size, and is there any major anomaly. So for the second one is micturatin cystourethrogram, which is MCUG. So we can find is there any vesicourethral reflux or intravesical obstruction. So next is DMSA. So DMSA is dimercaptosuccinic acid. It is a radioactive compound. And DMSA will enter the kidneys, and it is concentrated in functioning kidney tissues, giving an indication how the kidneys are working. So if the uptake defect in early phase, it indicates inflammation, while if the uptake defect 6 months later, it indicates permanent scarring. So next. So an accurate diagnosis is extremely important, as a false diagnosis of UTI will lead to unnecessary intervention that are costly and potentially harmful. So diagnosis is made when the bacterial culture of greater than or equal to 10 to the power of 5 colony-forming unit per milliliter of a single organism are symptomatic, plus the bacterial culture of 10 to the power of 2 to 10 to the power of 4 colony-forming unit per milliliter of a single organism. And the box below shows that 3 parameters in urinalysis, which is leukocyte esterase, nitrite, microscopy, carry the highest sensitivity and specificity in diagnosing UTI. So next is management. So the goals of the management is to eradicate the infection, prevent urosepsis, and reduce the likelihood of renal damage. So most children older than 2 months with UTI can be safely managed as outpatient as long as the close-up is possible. And oral antibiotics are effective for outpatient treatment of UTI, including cystitis and acute pyelonephritis, and it has been shown in the table 1. And timely treatment of acute pyelonephritis, particularly in younger children, is imperative to prevent renal injury and potential scarring. So next, the hospitalization for administration of IV antibiotic therapy may be indicated for children with suspected UTI, depend on the severity of their symptoms. And very young infant, those presenting with toxic appearance, severe dehydration, vomiting, or intolerance to oral medication should be considered for hospitalization. And the administration of IV antibiotics should be continued for a minimum of 3 days until the blood culture results are negative, or for a minimum of 24 hours after resolution of symptoms. And it is shown in the table 2. So next. Next is prophylaxis. So prophylactic antimicrobial therapy for UTI is aimed at sterilizing the urine in order to prevent renal damage and scarring. And it should be considered in children with history of recurrent UTI, BUR, immunosuppression, or partial urinary obstruction, and be continued until resolution of the underlying predisposition. And the prophylactic dose of antimicrobial is 1/4 to 1/2 of the therapeutic dose for an acute infection as shown in table 3. Next. So this is my references, and that's all from me. Thank you.
Okay, references need to be corrected also. And it is better if we can separate one slide for newborn and early infancy, because most of the recommendation for it is for them is to give IV antibiotics for 10 to 14 days. And we recommended, if severe or repeated, to do MCUG and DIMS scan, all this to diagnose the VOR, okay, which in the unit or early infancy, you are not retrieve that adult one, which are going to do injection by dye and like that to check the urinary system. Of course, of all significant cases of VOR, they need prophylactic antibiotic for longer time. It may be up to 1 to 2 years according to the severity. Okay. And you need to add just what is the difference between lower urinary tract and the upper urinary tract? I mean the pyelonephritis by its name, it's its own flag. Okay. So if we found pyelonephritis, we must go for IV. We must be very cautious. I mean, like you speak, if the patient starts with high fever, vomiting, general signs, pain, shivering, all this, must take care between differentiation, just lower urinary tract infection or pyelonephritis. Okay. Good presentation also. Do you have any questions?
Assalamualaikum warahmatullah. Can I ask one question?
Yes.
Ada soalan juga?
Okay.
My question is, why does chronic the importance of asking history of chronic constipation?
Chronic constipation, because wait, So, because from what I think, urinary constipation can also cause urine stagnant. Is that true, doctor?
Yeah, it is. There is many studies that constipation already accompanied by increased frequency of UTI, and there is many interpretation. Most of them said because the child or the one with constipation is going to sit on the toilet many times trying to avoid, and this will precipitate him to catch infection.
Okay.
Okay.
Thank you, doctor.
Okay, but many cases in medicine is just observation. We are trying to know what's behind, but sometimes can't conclude. Okay.
Okay.
Okay, thank you.
Welcome. Now the attendance now is 33. Is there anyone absent today?
I'm not sure, doctor, but there are some students who have problem with their internet connection. So they like, sometimes they are there, sometimes they lost connection.
If anyone didn't attend the day as all, you must inform Sister Farah, please, and give her the issue if there is internet problem or other, so we can analysis and see what is behind. Okay.
Okay, doctor.
Do you need to do a correction? It appears like references and the point which I give everyone, and you can resend it inshallah to me. Okay. Thank you, and see you again. And the good point that you already add the case scenario inside your presentation, which is a good thing. The last one you're marking will be Noor Hidayah will got 8, Sharifa will got 8.5, and Noor Afika will got 8. Okay, from 10.
Okay, doctor.
Okay, you are
Thank you,
welcome.
doctor.
Welcome.
Thank you, doctor.
Assalamu alaikum warahmatullah.
Waalaikumsalam.
Salam.
Thank you, doctor.
Thank you, doctor.
Woi.
Assalamu alaikum.